When the humerus is forcibly translated anteriorly out of the glenoid fossa, the physical displacement rips through the joint static stabilizers. This trauma typically shears the antero-inferior glenoid labrum, a Bankart lesion, and severely tears the surrounding fibrous joint capsule. Down at the microscopic level inside that torn capsular tissue, the mechanical rupture severs the local capillary networks and arterioles, spilling whole blood directly into the interstitial space. The immediate physiological priority is hemostasis. The direct physical trauma to the vascular walls initiates an instantaneous myogenic spasm, causing the smooth muscle of the severed vessels to contract and restrict blood flow into the joint space. Simultaneously, blood platelets spill into the injury site and contact the newly exposed subendothelial collagen of the torn vessels. This contact activates the platelets, prompting them to secrete thromboxane A2, a local hormone that drives further vasoconstriction. Inside these activated platelets, internal proteins, specifically actin, myosin, and thrombostenin, rapidly contract. This mechanical compression forces the platelets to degranulate, releasing factors that attract even more platelets to plug the microvascular breaches. Within seconds, the mechanical force of the dislocation has triggered a localized biochemical lockdown. Containing this initial hemorrhage is the necessary first step that sets the stage for the highly orchestrated tissue repair sequence to follow. As the platelet plug forms during the first 12 hours, the traumatized capsular tissue releases a complex of phospholipids and lipoproteins known as tissue factor, triggering the blood coagulation cascade. This sequence of chemical reactions converges on a single rate-limiting step, the formation of a complex known as prothrombin activator. Once present, prothrombin activator catalyzes the rapid conversion of a dormant plasma protein, prothrombin, into the active proteolytic enzyme thrombin. Thrombin immediately targets fibrinogen, a large soluble protein leaking from the damaged vessels. It cleaves the fibrinogen molecules, causing them to polymerize into a dense reticular mesh of fibrin threads. Initially, these threads are held together by weak hydrogen bonds, but a substance called fibrin stabilizing factor, released by the entrapped platelets, creates strong covalent cross-linkages between the fibers, constructing a rigid, unyielding plug that traps red blood cells. Macroscopically, this locks the clotted blood into place, fully halting the local capsular hemorrhage. This biochemical state is why clinical management often prioritizes protecting the joint in these first few days. Premature or aggressive movement of the shoulder physically tears this fragile, newly cross-linked fibrin scaffold, causing the capsule to rebleed and disrupting the timeline of the incoming inflammatory phase. Between 12 and 48 hours post-injury, the patient's clinical presentation shifts. The shoulder joint becomes highly sensitive, presenting with severe swelling or extracellular edema and sharp nociceptive pain. This swelling is driven by local tissue mast cells and blood basophils. Recognizing the tissue damage, they degranulate, flooding the microscopic area with massive quantities of histamine. This diagram illustrates histamine's effect on the vascular wall. It triggers profound local vasodilation and forces the endothelial cells to separate slightly. This increased capillary permeability allows large volumes of protein-rich fluid to leak out of the bloodstream and directly into the joint interstitium. Simultaneously, the damaged tissue releases bradykinin. Combined with the local tissue ischemia caused by the swelling, bradykinin directly chemically excites the nociceptive nerve endings, registering as severe acute pain. This fluid leakage actually serves a vital protective function. The high concentration of fibrinogen in the leaked plasma clots in the tissue spaces. This effectively walls off the injury site, preventing the spread of necrotic cellular products and keeping the local environment contained for cellular clearance. The acute edema and pain are essential biochemical mechanisms required to quarantine the torn joint capsule. Suppressing them completely removes the physiological boundaries necessary for the next phase of healing. With the area walled off, the necrotic tissue must be cleared. Inflammatory cytokines like tumor necrosis factor and interleukin-1 alter the local vascular endothelium, forcing the cells to express specific adhesion molecules, including selectins and ICAM-1. Circulating neutrophils bind to these adhesion molecules. They roll along the endothelium, bind tightly, and then undergo diapedesis, physically contorting to squeeze through the widened capillary pores and into the tissue space. Once outside the vessel, These neutrophils follow a chemotactic concentration gradient, moving directly toward the highest concentration of inflammatory markers at the site of the capsular tear. Within the first 48 hours, they are joined by monocytes migrating from the blood. Upon entering the tissue, these immature monocytes swell up to 5 times their original size and develop large numbers of lysosomes, differentiating into highly active macrophages. These macrophages possess an immense capacity for phagocytosis. They systematically engulf and digest the necrotic joint tissue, as well as the dead neutrophils left over from the initial wave of the immune response. Once the debris is cleared, these macrophages undergo a critical transition. They shift from a pro-inflammatory tissue-destroying phenotype, known as M1, to a reparative M2 phenotype that begins secreting vital growth factors. This marks a critical clinical intersection regarding the use of NSAIDs. While early administration of anti-inflammatory drugs will reduce prostaglandin-mediated pain, it can chemically blunt this mandatory M1 to M2 macrophage transition. Interrupting this cellular shift starves the tissue of growth factors and impairs downstream repair. Moving from day 3 to week 3, the clinical swelling begins to subside, leaving the patient with profound joint stiffness. Microscopically, the provisional fibrin clot that initially plugged the capsular tear is being dismantled and replaced by highly cellular granulation tissue. Because the isolated injury site is oxygen-deprived, the local tissue hypoxia, combined with signaling from the M2 macrophages, triggers the synthesis of vascular endothelial growth factor, or VEF. VEF initiates angiogenesis. Local endothelial cells dissolve their basement membranes and rapidly reproduce, streaming outward to form new capillary tubes that re-establish a blood supply deep into the avascular injury site. This newly formed vascular network acts as a physical lattice. Fibroblasts migrate along these new capillaries, infiltrating the gap in the torn joint capsule. The fibroblasts first secrete a dense ground substance, composed primarily of hyaluronic acid and chondroitin sulfate, acting as a gelatinous filler to space out the incoming cells. Following the ground substance, the fibroblasts begin depositing type 3 collagen, actively bridging the physical gap in the capsule to restore basic continuity to the tissue. However, this early type 3 collagen is laid down completely haphazardly. Because the fibers lack alignment, this provisional matrix possesses minimal tensile strength. This creates a deceptive clinical phase, often called the danger window. At 3 to 4 weeks, the pain drops and the patient feels capable of moving. But because this highly cellular type 3 matrix is mechanically weak, returning to high-impact activity places the joint at an exceptionally high risk for recurrent dislocation. The final phase of healing, remodeling and maturation, spans from 4 weeks out to a year or more. For the shoulder capsule to function again as a primary static stabilizer, the structural integrity of the tissue must be restored to a level that can withstand significant mechanical loads. To achieve this, enzymes known as matrix metalloproteinases begin breaking down the disorganized temporary type 3 collagen scaffolding. In its place, the fibroblasts deposit type 1 collagen, forming thicker, highly organized, and densely cross-linked bundles. The orientation of this new matrix is dictated by mechanotransduction. Cells detect mechanical loads placed on the tissue, physically aligning new type 1 collagen parallel to lines of stress. This makes rotational physical therapy mandatory. Controlled torque informs fibroblasts exactly which direction to align collagen cables to resist future dislocations. As the tissue strengthens, its metabolic demand drops. The vast network of capillaries that formed during angiogenesis is no longer needed, and the excess vessels undergo programmed cell death, or apoptosis. The tissue transforms. What was once hyperemic, cellular granulation tissue matures into a dense, cross-linked, and relatively acellular fibrous scar. While this mature scar tissue may never regain 100% of its original pre-injury elasticity, the type 1 collagen bundles successfully provide the critical tensile strength required to stabilize the glenohumeral joint. If the joint is kept fully immobilized during this critical remodeling phase, the collagen cross-links chaotically, cementing the joint into a severe contracture known as adhesive capsulitis. Successful recovery happens only when clinical management respects and actively guides the biological timeline.